Hello guys, today let's learn about nasopharyngeal carcinoma. Coming to etiology, it is mainly seen in Chinese and India, mainly in the northeast part due to Mongoloid origin. It is mainly due to Epstein-Barr virus, okay? So nasopharyngeal carcinoma is mainly due to Epstein-Barr virus or environmental factors such as smoking of tobacco, opium, working in industries where there is lot of smoke, nitrosamines from dry salted fish, smoke from burning of incense sticks. So these are the etiology for nasopharyngeal carcinoma. Most common site of origin is fossa of Rosenmuller. So just behind the opening of eustachian tube, we have a cushion of fat known as torus tuberous. And just behind torus tuberous, we have fossa of Rosenmuller, which is the most common site of origin of nasopharyngeal carcinoma. Most common histopathological type is squamous cell carcinoma. Okay, squamous cell carcinoma. Commonest presentation is cervical lymphadenopathy because of rich lymphatics. Okay, so the most common presentation is cervical lymphadenopathy because it has very rich lymphatic supply. Males are 3 times of more risk than females. Extension and clinical symptoms we'll see. Symptoms are almost same as JNA, but JNA is seen in young individuals, but here it is seen in old individuals. And here in nasopharyngeal carcinoma, bleeding is not profuse or unprovoked, but in JNA it was profuse unprovoked bleeding. Okay, so other clinical features are nasal obstruction. In otological, we have unilateral SOM that will cause conductive hearing loss, then cranial nerve involvement and mild blood stain discharge. If we talk about extensions, if this grows into nose, it may cause nasal obstruction and eustachian tube obstruction causing conductive hearing loss and serous otitis media. If it grows into sphenoid and cavernous sinus, it can cause cranial nerve 2nd, 3rd, 4th and 5th, 6th nerve palsies. Okay, 2nd, 3rd, 4th, 5th, 6th nerve palsies. If it is small, then there is no major symptoms, only cervical lymphadenopathy will be seen, and this is the earliest and commonest manifestation of nasopharyngeal carcinoma. If it involves foramen of a skull, it can involve almost all the cranial nerves. Okay. If cervical sympathetic chain is involved, then it can cause Horner syndrome. What is jugular foramen syndrome? Jugular foramen syndrome is 9th, 10th and 11th nerves are injured in jugular foramen. So in case of unilateral serous otitis media, if it is in older people, we can think of NPC. If it is in young individuals, we can think of JNA. What is Trotter's triad? Trotter's triad is hallmark of NPC. In Trotter's triad, what you'll see, conductive deafness due to eustachian tube block. Okay, so first thing is conductive hearing loss. Second is ipsilateral temporoparietal neuralgia due to 5th cranial nerve involvement. And then we have palatal paralysis because of 10th or vagus nerve involvement. Okay, so conductive hearing loss, ipsilateral temporoparietal neuralgia and palatal paralysis. This is the Trotter's triad and this is the hallmark of NPC. Okay, so here you can see conductive hearing loss, ipsilateral immobilization of soft palate and ipsilateral trachea and facial pain. In the starting, I have said that it has very rich lymphatic supply. So what are the lymphatic spread you can see? So what are the most common lymph nodes involved? The nodes between angle of jaw and mastoid. Okay, so nodes between angle of jaw and mastoid. Angle of jaw and mastoid. Then nodes along spinal accessory nerve. Then in posterior triangle of neck and host triangle. Do you know what is host triangle? Host triangle is also known as supraclavicular triangle or subclavian triangle. So here you can see host triangle. It's also known as supraclavicular triangle or subclavian triangle. So host triangle is bounded by sternocleidomastoid, then clavicle inferiorly and omohyoid muscle or clavicular head of sternocleidomastoid. Okay, so this is the host triangle. So now you know about the lymphatic spread. Nodes in angle between jaw and mastoid, nodes along spinal accessory nerve, and in posterior triangle of neck, that mainly in the host triangle, also known as supraclavicular triangle or subclavian triangle. Coming to diagnosis. So investigation of choice is biopsy. So you have to go for histopath examination. Then endoscopic evaluation, imaging, MRI is the investigation of choice. Then audiological test, pure tone audiometry, impedance audiometry. Then we have to screen for EBV. As I have told you, Epstein-Barr virus is the common cause, so you have to rule out for Epstein-Barr virus. So you can go for viral capsid antigen and early antigen detection. So if we have antigen IgA against these, okay, viral capsid antigen or early antigen, then it can be used as tumor marker, but it is usually not used because it cannot monitor and it cannot be used for screening or recurrence. Okay, so those antigens are not used for screening, but EBV DNA can be used for screening, for monitoring, for recurrence and for screening. So this is a newer advancement that EBV DNA can be used but not that antigens. Coming to tumor staging or TNM staging, it is given by AJCC, American Joint Committee for Cancer. So we have T1, T2, T3, T4. Very simple. When nose, nasopharynx and oropharynx is involved, it is just T1. When parapharyngeal spaces are involved, it is T2. When base of the skull is involved, it is T3. And when it goes intracranially, means intracranial spread is there, it is known as T4. Okay, so T1, T2, T3, severity of the involvement. Coming to N stage, we have N0, means no lymph node. Okay, and that is very rare because the hallmark feature is lymph node involvement. Then N1, less than 6 cm of unilateral supraclavicular lymph node involvement. N2, more than 6 cm and bilateral supraclavicular fossa lymph node involved. And N3 is more than 6 cm. Okay, coming to M staging, that is metastasis, we have M0, no distant metastasis, and M1, distant metastasis. Okay, so stage 1 and 2, in stage 1 and 2 will go for radiotherapy and then curative management. In stage 3 and 4, since it is highly severe, we have to go for chemotherapy and then radiotherapy. Other treatment is IMRT, that is intensity modulated radiotherapy. Now let's quickly see the difference between JNA and NPC. JNA, it is benign, whereas NPC is malignant. JNI is seen in juvenile, whereas NPC in older age group. JNA is mainly in males, and that is because it is testosterone dependent. And NPC is also seen in males 3 times more common in males than females. JNA, the most common site is sphenopalatine foramen, but in NPC, that is nasopharyngeal carcinoma, the most common site is fossa of Rosenmuller. In JNA, the bleeding is recurrent, unprovoked, profuse bleeding. Very important, recurrent, unprovoked, profuse bleeding. But NPC only blood stained. Okay. Usually in JNA, the cranial palsy are 2nd, 3rd, 4th, 5th and 6th. But in NPC, if it involves the brain skull, it involves almost all cranial nerves. Okay. In JNA, there is no lymph node involvement as such, but in NPC, there is lymph node involvement. The diagnosis is done by CCT. In NPC, it is done by biopsy. You should keep in mind that biopsy is contraindicated in JNA. Treatment is, first you have to go for embolization of the feeding blood vessel, then go for the surgery. In NPC, you have to go for radiotherapy, chemotherapy and IMRT. IMRT is intensity modulated radiotherapy. So this is difference between JNA and nasopharyngeal carcinoma. Thank you so much.